Any examples? Toys?
I'm going to go find that stuff because they didn't put anything in here for us.
Yeah, I'd like to play. Well, we'll see what we can do. Okay, so what we're going to talk about here, and this becomes the big deal. I'm new. For those that don't know me, only some people do. Hi, I'm Dr. Lynn Meyer. I'm brand new. I got this job and moved here in 3 weeks from Wisconsin. So if you think Maryland talks fast, wait till you meet Wisconsin, because I'm faster. So slow me down, wave me down, whatever. But I've taught a long time. I'm old. That's all you need to know. So anyway, I do not know yet where you learn to insert IVs in the program.
Level 3, right?
All right, so that helps me learn you as well. Okay, so as we're moving into this last semester, you're getting into the big lines, the fun stuff, okay? So we're moving on, and what we're talking about is the central venous accesses, and some of the big thing is how do you manage it? And it's always about preventing complications, as she talked about with the TPN, right? If we are putting something in that's sugary and bacteria is going to grow, now I'm talking about the line it's going to go in, you better be sterile. Does that make sense? So we're just going to build on that maintenance of how we do things. Oops, went back too far. All right, so why do we use it? This is for the big guns, okay? You can give blood in a peripheral line just fine. But chemo, why do you think you can't do chemo in just a little peripheral line? Lots of problems. What if it leaked? Okay, extravasation, and that's the big thing. So we need to get it in deeply, okay? Sure, we can do blood, especially if they're in a trauma. We can put a short-term short one in, okay? And we'll talk about that coming up. Some are long-term. Some are just short-term, and it's emergency. You have no veins available here. Why in an emergency could we not maybe use the arm? Injury, blood loss, vasal collapse, right? So they're going to go into jugular. They're going to have to get in fast, right? So those are our short terms. They're the Band-Aids till we figure out where we're going. Long-term antibiotics. Anybody in here ever been on a PICC line? They're not fun. We'll talk about them. They're the ones that start here and end up in. They're crazy. But if you're going to be on Vanco for 6 weeks because you have MRSA, is that going to be really hard here? Yeah, because what do we worry about? What's a big side effect of Vanco? Red man syndrome, because it's a vesicant and it can cause blisters. So if we're going to give a drug over a long period of time, 6 to 8 weeks, we're going to be poking. Let's put something permanent in. 6 to 8 weeks permanent. You know what I'm trying to say. Okay. Does that make sense? And she just talked about TPN because you're not going here. You got to go big. All right. So what we worry about is sepsis. So I cannot stress enough, because not only are they in a trauma, cancer patients are immunocompromised. They don't have the ability to fight infection. So if you're not a good hand washer and not into all this sterile, and when we do them, we are masked and so is the patient. Okay? So it's a sterile field. You open all the packaging up sterile, and that's just to do the dressing change. It's not like just a little slap your opsite on and move on. And the other thing is, again, the big safety thing is what do patients want to do a lot? Look at what you're doing. And what are they doing? Breathing right into that spot. So again, it's essential that you put the mask on the patient as well. If for some reason airway is the issue, get somebody in the room to talk to the patient, at least to kind of keep them redirected, because it's habit. I want to watch what you're doing. Okay? And that is a big safety thing to prevent sepsis. One of the new things that's come out, and they are pretty darn cool. At the insertion site, whether it's in the neck or here, we're putting on what we call a bio patch. And it's kind of preventing this barrier so organisms can't get in. You'll see them, they're about this big, and they just kind of stick them in, and it's got a pre-cut slot so the tube can come out. But that's that's making like a barrier, because we can get staph and strep on our skin. Do you want that going in a big hole that's going to end up right before your right atrium? I know I don't. So as we keep moving on, things advance, and these again, it's going to depend on your hospital, but these bio patches are real new. And are they going to be tested off to do these in clinical?
To do
these dressing changes?
Oh yeah, they can do the dressing changes. That was a level 3 too.
Oh please. Oh, so you've been through this. So I'm not teaching you anything new, but I really want to stress because this is where you don't want your instructor reminding you to mask the patient. Does that make sense? Okay, so I guess again, work with me what you know, then act really, then we'll shut up. It's okay, like we know this, all right? Because I don't want to reteach what you know. I want to do new.
They need to know this, so doing it again is fine.
Okay, so this is where I'm really getting at everything is sterile, okay? And you may even, if you have somebody that's going to move a lot, you may want some help because what are their hands going to be? On your sterile field, right? If it's the arm or the neck or if they have a dome. All right, so we talk about air embolisms. Are we in a vein or are we in an artery? Just asking, because I've had students tell me it's sitting in the artery. It's in the vein. Right. So this is the deal. Can people die of air embolisms? Sure, but they need a lot of air. If it's sitting in an art line and they get an air embolism, bye-bye, because you're going to be in trouble. So I just want you to be clear. We're going to talk about art lines and cardiac. But you're in a vein, so just don't tell your instructor you're in an artery. I have a hard time listening to that. Okay, does that make sense? So maybe they do have an air embolism. Oh my God, it happens. What are you going to assess on the patient? What do you think I would show if I got an air embolism? Usually confusion, something respiratory. So because remember the brain needs oxygen, okay? And can it travel to your brain? Eventually it could. Okay, so, get them back, yeah, but then you're going to be calling a rapid response anyway. It's fast, and you're going to want people there to help you. Okay, thrombus, it's at the tip. It's usually at the tip, because again, you're going to be, if it's a PICC line or a midline, one of the big assessments, if you remember, is to measure the arm, and look how many dots are down. Right? There's little, it's like the NG tubes, they got the little marks. So I like to put, I see 3 dots.
Yeah, there's some on here when she's done lecturing if you guys want to come up and peek at these guys.
Yeah, it's like any tube that usually goes in a patient, somewhere has markings or numbers that you know where to count back to and report off with.
Each one is a centimeter.
Okay. I just know where I count my lines. All right, and measure my arm. All right, so how do we know it's working? This is where on a peripheral line, yeah, you check for a little blood return, but not like you need to do here. And there's for 2 reasons. One, we have to check that patency because I gotta know I'm in the right spot, and they can move, they can pull. When they're here, they're barely stitched in. Okay, so you can pull them, they can manipulate a little bit, but they can move, and it's really fun to pull them out. So, can they pull here?
They don't let them remove the PICC line.
They're fun. Because you just do this. It's like, when's it going to be done? Because it's about 60 centimeters long.
But
it's fun.
We encourage you to all watch.
It's fun. It's like, is it ever? You're like, really? It's just like, keeps coming. Okay. I want to go back to this air embolism for a minute. I know I was kind of being, it's not that big a deal. But one of the big things that's changing with PICC lines and this is, here again is the importance of the clip, all right? Anytime you are going to be cleaning, changing the cap, caps come off real easy because they're just not that much. Always have this clipped because if you're like me, it's, oops, where'd it go? And where's the other one? And if I don't have it clamped, where's the air gonna go? In. And it's easy to drop these. I mean, you're in gloves, you're hot.
Rubbing them on your pants doesn't count though. Please get a new one.
Just do what I tell you to do in lab. Don't watch me. Okay, whatever. All right, so that, I just wanted to bring that up, that clamp is key. Now we're getting into more advanced catheters that are having a pressure back, like an art line internally built into them, that don't have a clamp. But if you see a clamp, make sure it's clamped. It's just a word to the wise. One of the things about flushing, you have to have a 10 mil syringe. So usually syringes are 1 mil, 3 mil, sometimes 6, and a 10. It has to be a 10 for pressure. It's all about pressure. PSI, pressure per square inch.
What's the difference if I flush with a 10 ml or a 3 ml? Which one's going to have more pressure? The 3. So if you're flushing with the 3 ml and you just push it in there, it's going to bust your line.
I want you to think about this. Remember the first group, but the second group, hear this. It's like your coronary arteries. If there's narrow, what happens to the pressure behind it?
Goes up.
It goes up. It's the same principle with a small syringe. If you start keeping these principles together, you start applying it to body systems and everywhere else. Does that kind of make sense? The narrower it is, the higher it goes behind it. All right. So that's Bible. 10 mil syringe. I don't care what state I teach in. That's what I say every time I talk about these. Verifying patency. Again, I want to make sure it's easy. If I'm kind of sluggish, always make sure it's not clamped.
Yeah.
Been there, done that.
Especially when your teacher is standing there, so we make
Because you're so nervous, you're like, it won't go. And then you go
wrong?
white.
I'm like,
Mask is on, the patient's here, teacher's here, and you're like,
yeah.
okay. So it's kind of like the tourniquet. You forget to take it off. Same principle. Okay. So always for ease of flushing, know where your clamp is. I cannot tell you that enough. And you want to see a good blood return. You've had this skill, but I want to remind it. If it's been heparinized, you need to take whatever amount of heparin was in there out. Because if you check and push, what are you doing with the heparin? And how would that be if the whole idea is you're not in and out, but I was in and out at home with mine for 8 weeks. How much heparin would I get if I was doing meds every 8 hours in my body? Yeah, a lot. Okay. So again, just know what you've got before you go in. So those are going to be your biggest things here. And again, we talked about extravasation. You shouldn't see it. That's why we use it. And are you going to see blisters? No, because where is it? In. But if they're saying, oh my God, it's burning, will you please stop what you're doing? Okay. Do not push further or turn the pump on. Yeah, honey bun. Okay. With this 10 mil syringe. Okay, everything's a 10 mil syringe. That is a great question, honey. No, okay. No, you bring up a great question, sweetheart, and I love when you ask
question,
it.
so everybody
I'll
hears, 'cause I didn't
repeat
hear
it.
it.
Okay, so she said, why do you pull the heparin out? Doesn't it go into your body? Okay, this tube is short here, and see it's here, and it's back here. Okay, this is a short one. The heparin sits in the tube, so thrombi don't form. And that's the problem of the microthrombi, because of this little tip is small.
We don't flush anything with heparin anymore. Usually the only thing that gets
If they have
heparin
an old girl showing
is
in.
or the quartz. If we're going to pull the Huber needle, which she's
And I'll
getting to,
talk
then
about
we'll
those
heparinize
coming
it,
up.
But otherwise,
Again,
we used to sash everybody. We don't do that anymore.
it depends on some places
some
still
places
are a little
still do.
archaic and do.
Really?
You'd be surprised. Again, I always refer to your agent policy. Refer to the agency policy. It'll tell you. All right, so we have different types of lines, different words that go around, and most commonly you're going to hear it called a PIC line. That's the big white one that sits out here. Arm.
Most of ours are purple, yeah. We use the power
White,
picks,
purple,
yeah.
power picks. They're changing. And again, it's who's the people putting them in, and guess what? If you're on the pick team, you usually get to pick which ones are the easiest ones to put in.
Or the hospital decides which ones are the cheapest.
Yeah, same.
Or the rep took somebody on vacation.
That too.
It happens, trust me. All right, so we have different kinds. So we call them tunneled and non-tunneled. Non-tunneled is this jugular. It's a quick cut down. Who works in EDs? Raise your hand. Have you seen them? It's quick. They lay them down. Resident, somebody comes in, boom, they're right in the jugular. They can thread it right down. It's not tunneled. Tunneled means it's inserted here, comes underneath the skin, and comes up. So it's either a direct hit.
There's a tunneled one on the dummy here on the chest.
Okay, I'm like, where?
No, I'm sorry. On the chest.
Well, there's small letters, but I don't see
On
that.
the chest of our dummy.
Okay.
There's a tunneled one.
So just so you know the term, that's what it means. Now, who is more at risk for infection? Systemically for sepsis. A jugular that's a direct hit, or something that's tunneled underneath and then comes up. Straight in. And sometimes they leave them in for a week. So what? And they've been in a trauma and they've been diaphoretic and gross. Your ports, it's a direct entry. I'm talking sepsis. Does that make sense? You have more problems with those non-tunnels. They're short term. Implanted ports, I believe she's got a slide coming up and I'll talk about those. Other ones, and again, I'm from Wisconsin. I haven't been clinical down here, so I haven't seen your purple tubes yet, but I'll figure them out when I read the policy. But do you see what I'm talking about? Does it matter the color? Did my nursing practice change? Not at all, and that's what we're trying to instill. It doesn't matter. The theory behind how we do things and the why are the same. Does that kind of make sense? Okay. I'll learn the colors of the tubes if I find the hospital. All right. All right. We can have single or double lumens. This is a single. So someone like me that had meningitis, I only needed one thing. So I only needed a single. But maybe you need to be on 2 incompatible drugs. Or you're going to be in the hospital getting blood, TPN, and antibiotics. You all need a big line, right? So then they're going to get one that's got 3 on it. So the TPN can be in one. Usually one's labeled for blood and one's antibiotics. Now, how can they all go together if they're incompatible? The cool thing is, this is, if it's 3 lines, it's like 3 tubes in one. And they actually, what I really want you to look at is the exit ports.
I tried finding a turple over there. We don't have any. But the exit ports, there's 3
They're
separate
very
ones.
small.
Because if you cut a PICC line that has like 3 and you cut it, it looks like 3 teeny tiny little straws
In one.
inside that one.
And they have different portals of, well, it's obviously blood comes this way, but I do know cardiac. But what it has is like, if my TPN would come out here, but my blood would come out here, and my antibiotic would come out here, even though it's like in this much line. But it hits the bloodstream differently, and it doesn't mix.
So they do them one at a time and it just goes.
They can run concurrently. I can run them all at one time.
So
And they're coming out at different locations.
Inside the body.
So what, the whole reason that we use central lines, right? So it's going into that subclavian, or the, I'm sorry, superior vena cava. What's the blood doing there? Is it just kind of like swooshing along like it is in your veins? No. Super turbulent, right? So because it's coming out at different areas and the blood is so turbulent right there,
It doesn't
ever mix. It doesn't ever touch enough where it's not already diluted.
So maybe your patient had MRSA and something else and they need long-term antibiotics. Maybe they'll get 2. I can run them at the same time. Kevin.
So the number of lumens determines the type of treatment that the patient is receiving, or?
I kind of look at it at 1, you only need 1 thing. 2, you need 2 things. 3, you need 3 things. Now, the other great thing about it is we can draw blood off these. Ah, how nice if you need TPN and your labs drawn every morning to make your TPN recipe at the pharmacy. No pokes.
That being said, that if you do have to draw labs and you have TPN running, remember what is TPN full of? Sugar. You're going to want to stop that TPN for like 10 minutes before you pull anything off of it and flush it really well. just to make sure, because otherwise you're gonna get a sugar bath that's like sky high.
Okay, so let's talk about that again.
Can we pull blood samples off of that afterwards?
No. The only thing you can do as a student is flush it.
Okay, I'm gonna really screw up. If you guys are in my clinical group, don't come back and say I let you. I need,
Every college.
I need what you can't do list.
Well, a lot of it's per hospital.
I know.
But per college,
Okay.
the only thing that they absolutely can't do during level 4
Is blood.
IV push,
And blood.
blood, and anything with a central line except flushing.
Okay. Sorry, I swore under my breath.
But they can hang IV meds,
Okay.
but they can't pull them. They can't
draw blood.
They can't IV push into them, draw
Okay.
blood off of them. You can change their dressing.
Yeah, hon. Nothing's crazy when you're learning.
We're all learning every day.
You're pushing your meds and everything into the center of the superior vena cava as it enters the heart, and then it goes through and gets oxygenated. Why would you not put it in when it leaves the heart? Or were you using the heart to like push it through?
It'll make more sense. It's the way it gets oxygenated and perfused through the body.
So you wanted to have.
And our arteries are just for bleeding out. And about the only time we worry about our art lines is to measure pressure. I don't want to be in an artery. I don't want to be in a vein. Less complications all around. That kind of sense. Right. But really the way it does is because it starts at the right atrium, it's still blending, it gets to the right ventricle, it's gonna get, and it gets out to the system, because you're systemically giving medications. So you wanna get through the cardiac cycle to get it because what if you have meningitis? I gotta get it up here. What if you're septic from pneumonia? I gotta get it to the lungs. What if you have MRSA and are septic in the kidney? I gotta get it into perfusion, and the best way, the best bang for your buck, because we back up, we get lost in the shuffle, the same amount will come out with your output. Does that kind of make sense? It's difficult until you kind of see it. I still had the hardest time when I was learning it, seeing 3 straws in 1 tube. Like, no, and then I cut one open, and I went, oh. My rationale for everything is, I always ask, is it a teaching hospital? Because then I can teach. And then I cut it open. Okay. Good questions. So this is, again, I got a little ahead because I didn't write this PowerPoint, but I think it's awesome. I think it's awesome, but I didn't know this was coming.
Okay.
This is the principle for the 3 lines. And the triple lumens usually have a red, and red is usually blood products or blood draws. It's just kind of our universal speak. Red is for draw, red is for blood. Does that help? That's what I was trying to get. I just got a little ahead of the slide. Anybody need time to redo notes? I can speak again.
I just want to know.
No?
At the openings at the bottom, the other picture, yeah. Like,
There's 3 of these.
they're
There's
all
3 of these
entering-
little holes. One's probably here, one's probably here, and one's probably here.
But they're all entering the.
They're
superior
like these
vena.
3 little tubes get put into this one tube. And they're shorter than each other. One's long, one's medium, one's short.
So they're entering the SVC at different times?
Right.
Okay.
Got it? I want you to see that in your head. Who needs it again?
I was looking at the ATI, like, and it has 2 pictures of exactly what you're talking about. So they actually show the.
You are lovely. What page in ATI are you on?
It's the CVA, skill module.
Go to the skill modules. They'll show you pictures, but if you need more help
I think that
after.
there are links in the course to that, the blood, the cvads, and the TPN. So when you go there, there's a picture exactly.
Okay, perfect. Thank you so much.
Technically, they should have walked you through first, but I figured it never really makes sense until we.
No, I think This is hard to visualize if you've never seen it.
Yeah.
Anybody else have questions before we move on? Okay, good. Bye. Oh, yeah, I'm just kidding. No, who does? Nope. All right. All right, so our non-tunnels, this is what I'm saying. It's a direct shot into that subclavian. We can do femoral and send it up the inferior vena cava. What's your risk of infection in the fem? Do you think higher? Sweaty, dark, damp, moist? Yuck. I don't want one there. But what if you were trauma here? You got to get somewhere, okay? So just like you can go in the femoral artery, you can go in the femoral vein.
A lot higher risk of infection.
Oh, huge, and moving and dislodging, and in fact, it's just awful. Now, the difference is when they put these in, there's a risk of a pneumothorax. Do you know what a pneumothorax is, where they puncture the lung and the lung shrinks up?
Test 3.
Test 3, never mind. Okay, now the other thing is, I don't care if it's a jugular or a pick or a port, you need a chest x-ray confirmed even if you have blood return. The thing is, it's coming up, right, into the right atrium. We don't want it in the right atrium. What would that do to the right atrium? Send it quivering. You don't want to mess with the electricity. So you may be getting beautiful blood return because you're in an atrium, but I don't want you there. Does that make sense? So don't let the blood return fool you. It's got to be before it.
So it's gotta be verified by X-ray.
Verified by x-ray. So if you can just Google central line and because what's going to happen, it's going to tickle that electricity and dysrhythmias are going to fly. It's got to be up in that vena cava. Now, I remember when PICs came out, because I'm so old. I was actually on the PIC team. That was dumb. But I put them in.
Why was that done? A lot of people enjoy that job. You didn't enjoy that job?
I loved it because I got to do fun stuff. But I look back at some of the things we did without real good education going,
Oh.
wow.
Yeah, but you taught evidence-based practice now.
At that time, that was evidence-based. See, 1, 2, 1.
We're gathering the evidence.
We were the gatherers of the evidence of what not to do. All right.
They were already around when I became a nurse. Just saying.
Just saying. All right. So again, if this is something you are interested in, you don't need advanced degrees. You need advanced training. Do you hear my words? You don't need it. Well, once you get advanced degrees, you can too. But there are nurses in facilities that are on the PIC team. Not usually a jugular. That's usually the doc or the resident or somebody in the ER or the ICU.
Unless it's a trained practitioner, they can do them in the ICU if they're at.
Again, they got to be
ICU.
really trained for that.
Yeah.
I never did here. We just did here. All right. Again, it's long. It's got to go. Do you think okay, my kid's 6'4". Do you think he needs the same size PIC line I do? No, I think we're going to have different lengths. He's got to get up higher, right? Because our arm lengths are real different. So again, that's why it's so important to know your centimeters. I didn't know. I forgot. Your marks, right? How long? And they can clip them and fix them and do all kinds of stuff to them. All right. That makes sense. Any questions? We good?
Did you already talk about taking it out?
No.
I don't know if I have it on a slide. So when you take out a PIC line, one of the things that you have to do is make sure that the tip is still there, and then count and make sure that you're at the same centimeters as, because there should be a little sticker in the chart for the power PIC.
Actual
Says
sticker.
it was 37 centimeters.
It better
And so
be
you should go and
37.
count and make sure that you're still at 37 and make sure it didn't break it off at all.
The other thing is, you may be asked if the patient is septic and they think the line is the source of infection.
That's great.
We don't cut. Sorry. Yeah, I'm giving you the answers. I don't even know what's on the test. All right. They don't take the swab from here. They cut the tip off and you put it in a
You
sterile
pull it
cup.
first.
Cut them open.
All right. But that makes sense because are you going to get staph and stuff from the body? It's kind of like not cleaning well before doing a urinalysis. You're not going to get the true bacteria that's growing. So they'll say, remove it, and then cut the tip. And you usually just put it like in a sterile urine cup, label it, and off to lab, and then they'll grow it out. All right, I have no idea what IAW, but to me, I see is dressing, change, and flush.
With.
Okay, and I was pretty close. In my mind, I went dressing, change, and flush according to agency policy.
In accordance with, yeah.
Thank you. I had no clue. This is where you have to be honest as students. How do you learn? By admitting what you don't know. Okay? And I'm just saying,
We
there's.
absolutely don't know everything.
I don't, and I'll just go, I don't know. I'll look it up. I didn't have time to look it up. All right. The other thing is, if I've got a PICC line in this arm, blood pressure's going this arm. Okay, that's huge. You don't want to be manipulating anything that could move around here. Okay? Again, occlusive. They can shower, but you better keep it dry. You don't want to be, every time you take it off, what are you giving risk of? Infection. And we like a good dressing to hang for a week. Again, depends on your agency. Again, redness, tenderness. All right, I already said about the clipping it. I'll tell you about a PICC line, and this is where it can be kind of like what? I had one in, and I'm a little, I don't think I'm claustrophobic, because I just don't. But I had to have it in for 6 weeks of antibiotics. And what I hated more than anything is I could feel the saline run up my arm. And it was the freak, the antibiotic didn't bother me, but that push of doing, because I did it myself. I don't need a nurse, I just need a long enough tube. I put an extension, I had my home care nurse put an extension on, who was one of my post students, just did it myself. She loved it. She'd put down my visit 1 hour. Here's your saline. Here's your med.
And a lot of patients will tell you they can taste the saline. You guys
Yeah.
have patients tell you that already?
So that's very different than burning. So be sure your assessment is a little more, tell me more, give me descriptors. Because if you're giving Vanco that's a vesicant and maybe it moved or who knows, do some more investigating. Does that make sense? Okay, and then leave them sit a minute and do it again. If the drug isn't involved, you know it's just the saline and reassure them. But it just was like, it was claustrophobic. All right. Tunneled catheters. We do use these, and they can be longer term, where we just stick them in. But boy, your source of infection is big again. But maybe they've had surgery. I've seen it for like a kid that needs chemo on a 28-day cycle. So they might just put this in here, a lot of lab draws, things are right up front. But what's really cool is, remember I talked about that bio patch, okay? Here, it's a whole cuff because it gives more protection across the whole skin, and then you bandage. We are just look at dressing changes. We used to do them every day on surgical sites. And now where you get your knee done, we don't even change them anymore. The doctor does the first day because we're learning, quit manipulating this stuff so much. We're creating the infections. That's evidence-based. Okay. Does that make sense? Okay. So it's like, what is that? So again, flushing's the same. Doesn't matter which one it is. Scrub it off. And if it is a minute, get your watch out. A minute is a long time. I worked with oncology patients way too long. I will do a full minute. And they're like, boy, you take a long time. You're right, but you're not getting an infection from me, if I can help it. And sterile gloves, sterile gloves, sterile gloves. All right, an implantable fusion port. I think the picture's on the next page first, so let me show you what this looks like. And we'll come back to it. It's implanted. So they do a little surgery, they stick it in, and then the tube goes where it needs to go. Does that make sense? Everything's underneath the skin. And then they sew it up. So being the old oncology hospice nurse that I was, it's really cool because you can actually put your fingers around it to feel it. You know where it is. Sometimes if they're skinnier, you can actually see the tube running, and you can feel the spongy center. I always, you know, they say watch your fingers with needles and all that. But the cool thing is about it, the needle, can you guys see this? If I bend my finger like this, it goes in like a hook. Because I gotta get through the skin, through the dome. Fingers here, dead center. And you might hear a ting when you hit the back wall of the dome. That's freaky. The first time you do it, you're like, ting.
There's one
Whoa.
in here if you wanted to see what it feels like after.
You don't usually put a needle in here, metal, on metal. Yeah, honey. Yeah, and it can be used up to like, what, 2,000-3,000 times.
Oh, I don't know. It's
They're years.
very
I've had
long
people
term.
for 5 years before they needed it changed. You're nodding. What do you? I know it's like 2,000-3,000 folks. It's ridiculous. Like they're like, oh my God, I've had the same dome for 5-8 years. You're like, okay, but how cool is that? To just take your pulse and then we can triple lumen you off that. We can do anything we want. And that bore at the bottom is big. I mean, you can massive dump into them. Yeah, it's amazing. But if I was gonna have a disease where I knew it was gonna be that long, I wouldn't want something here. Risk of infection's almost none. It's just when you poke. And boy, can you prevent that with good cleaning. No, nothing silly when you're trying to understand it.
So they have a port underneath the skin. So unless you're actually administering something through a needle, it's closed off.
Correct.
Correct.
So what we do is we get an order that says access the port. So you actually make it like a saline lock. I don't know how else to describe it. That needle, you need your special needle, and it's gonna get put in, and it's got a 1 lumen out, just like the longer whip on a peripheral site. From there, I'm gonna more tubes together, and then I can triple lumen it from there.
So who do you think these are good for if you can't see it and it's under the skin if it's not accessed? It's under the skin, you can't really see it unless it's accessed, you know, and it's not open. So for people who have super long-term stuff going on, they can go swimming with this, they can go, you know, your teenagers can go to the beach and not have stuff that they have to cover.
It's just, they're great. They're great. So back to your question. The needle, like, come look at it, honey. So it's underneath my skin, wash, 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 sterile gloves, and stick it in and it sticks out. About twice, it's the only thing I can do. She's got one. But it's, and you might hear old nurses refer to this as a Huber needle. I'm old. Yeah, honey.
Yes, listen to her question. You never know, it could be something
Yeah,
else.
the other thing is, you guys, if you don't hit dead center, what could you take that needle and hit? The tube. You see what I'm getting at? Because I said keep your finger, you gotta know where you're at. And they're great. The ting means I'm dead center. Yay! It's kind of like hitting the bullseye. It's a good thing. Because I can remember once in home care, I thought I hit the tube. I was scared to death.
The other thing is, the first time I ever accessed one, they sent me to day surgery before I ever accessed one to watch it be done and to show me. They don't ever just say go access your Huber port, you know? So you will have somebody show you how or get some sort of training before you ever do it.
Yeah, Baycare, you have to be checked off, and you have to call somebody. Like if you are not certified to do it, you cannot do it at Baycare. Yeah, so.
Don't worry, my clinical group, it's on my notes, what can they do or not do, because I don't want you doing anything you can't do. But if they've got it, let's go in and talk about it.
You're like, we accessed it with a Huber needle and then pushed some morphine. And that hung blood.
You know, I just got the job, I don't want to lose the job because of, you know, what do they say, follow the agency policy. Okay. I will, or IAW. What were you gonna say? If you're going to work in oncology, this is probably the most common place that you want to see it. It's, remember, long term. It can stay under there for years. If I can poke you, I only need drugs it's a one poke. That's why people like them. It's awesome. And then your arms are free. You can eat. You can do a lot more. Somebody else has a question.
My question is, peradventure, I have a patient that has this inserted, and the patient also have a pacemaker. How do I differentiate? Because you said you can see.
You'll be
so
able
how
to
would
see
I
it.
be able to
We'll
differentiate?
talk about pacers and cardiac. They're always put on a certain spot, and they're bigger. A dome, you have to literally I gotta find it. If you're chunky monkey like me, you might have to feel around. If you're skinny, you're gonna see the pacer, you're gonna see the dome. You'll learn to feel what they feel like by size and shape. This is a round dome about this big you're feeling for. That's it. Just this big. A pacer is probably this big in my fingers. So it's a total different feel. And a pacemaker goes, it's hard, plastic. This is a soft, mushy surface. So you will feel. It's all feel. It's kind of like palpating for your IV. You're going to feel what you're feeling for.
And location is always important.
Location is key too. Okay, great questions, you guys.
It's the best one because least amount of infection.
Again, because you're talking, they may have it in years. I don't want that surgery and something like that put in if I only need a 6 to 8 week cycle of an antibiotic and I'm cured. Does that make sense?
Yeah.
Good. You guys are asking great questions. So again, this is what we're trying to get at. If you look at the picture, it's bent and it's got a butterfly so you can hold on to it and go pink, and it goes all the way through the skin, through the dome. You guys know what butterflies are, the little soft tabs. And you just grab it right through your fingers and you'll find it. Now, is it a big deal if I did hit my own finger at that point? I hit my finger on the wing end. Does that make sense? I didn't mix blood. I hit my finger. I'm not even to the patient yet.
Just get a new needle, though.
Yeah, just get a new needle. Again, let's go. No, I'm just kidding.
I like to be Captain Obvious.
They'll say, but Dr. Lindmeyer said that in class. Okay, funny story about what Dr. Lindmeyer says in class and then has another instructor follower. So I'm just really honest. I can teach OB enough to get you through boards, but I will never work with babies. I say that now, but I just can't take the moms. But I was doing hematology, and I was talking about blood loss, and I was trying to relate blood loss and pseudoanemia to pregnant women. And I go, like when the uterus falls out after the baby, and they were having their OB test afterwards. I'm like, Linda, if they get the question wrong, uterus versus placenta, it was me. So sometimes if it doesn't make sense, this is moving just as fast as this, okay? So, hello? That didn't make sense. All right, again, we talked about the pressure and the size and the flushing and heparin and where you're at. All right, dressing changes again. Watch your policy. You can always do a dressing change as needed. Does that make sense? Obviously, you're not going to leave gunk underneath the thing. Any redness, drainage, jaw pain, something that you can see where it's radiating. If it's supposed to be here and you're hurting up here or over here, something's wrong, unless they're having a heart attack. All right. So again, always according to facility protocol. I have no more to say. Do you have any other questions? That was kind of fun not knowing what's on the next slide. These are the principles we're trying to get at, guys. What were the big